webs cause dysphagia for solids only. Liquids are able to make it down the esophagus without issue. So, again, pay attention to the guy in the back who forgot how doors work. Those liquids just squeeze on by. The third pillar of the Plummer-Vinson triad is iron deficiency anemia, hence the pale, anemic overalls. Once again, remember that this is just a manifestation of the presumed cause of Plummer-Vinson, chronic iron deficiency. Interestingly, patients with Plummer-Vinson syndrome are at an increased risk of esophageal squamous cell carcinoma, a result of chronic food entrapment within the esophageal mucosal webs, causing chronic inflammation and dysplasia in the esophagus. See how irritated that squamous tile looks? In fact, in this sketch, everything that we illustrate above that squamous tiled floor can increase your risk for squamous cell carcinoma of the esophagus. This even includes our next esophageal dysmotility disorder, achalasia. Achalasia is a neuromuscular disorder of the esophagus causing impaired relaxation of the LES and a functional esophageal obstruction. And when I say impaired relaxation of the lower esophageal sphincter, I want you to think of Michael Keaton over here, with that tight harness really squeezing down on that esophagus. And when I say functional obstruction, I mean an obstruction not caused by a mass or web. You see, with achalasia, the lower esophageal sphincter can't relax due to the loss of the myenteric, also called the Auerbach plexus. And now that I think about it, someone really should look into getting that safety plexus fixed. The myenteric plexus is normally responsible for producing nitric oxide and vasoactive intestinal peptide, or VIP, both of which help relax the smooth muscle in that lower sphincter. Because nitric oxide is a gaseous neurotransmitter, it's represented, as always, by nitric oxide exhaust. And VIP? Symbolized by that VIP backstage pass, of course. To highlight that both of these transmitters are decreased, the NO exhaust pipe is all bent and rusty, and that VIP pass is broken and falling to the floor. As a result of increased lower esophageal sphincter tone, the area just proximal to the sphincter dilates, and normal peristalsis of the esophagus is disrupted. Most of the time, the cause of achalasia is unknown. Actually, in other words, it's idiopathic. The old idiot sign taped to the back gag. Gets me every time. It's possible a virus causes an autoimmune response targeting the myenteric plexus. Or maybe there's some kind of genetic predisposition. We're not really sure. Achalasia can also be acquired, although this really only happens in Central and South America. That's because secondary achalasia is a complication of Chagas disease. You remember Chagas from Sketchy Micro, right? Che making out with his girlfriend over at Che's gas station? Well, we've brought back Che's gas to remind you that the amastigotes of Trypanosoma cruzi cause direct destruction of the myenteric plexus, leading to the same downstream effects of achalasia. Check out our Sketchy Micro video for everything on T. cruzi, including an in-depth analysis on the exploits of Che Guevara. Regardless of how it happens, achalasia has a very unique finding on imaging. On barium swallow, you'll see a classic bird's beak appearance, where that super tight lower esophageal sphincter sits. This shape is evoked by the beak of his mask, dilating a bit and then coming to a sharp point at the bottom. If you see this picture, you'll know right away that it's achalasia. A patient with achalasia will present with regurgitation of undigested food. I mean, that does look pretty painful. And dysphagia for both solids and liquids. Yep, this time liquids are affected too. Hence the backup of fluid at the funnel. Treatment for achalasia centers on opening up that lower sphincter. Procedures such as pneumatic dilations via EGD or esophagomyotomy can be effective, as can botulinum toxin injections into the musculature of the sphincter. If achalasia represents a lack of peristalsis through a dilated esophagus, diffuse esophageal spasm represents uncoordinated peristalsis. Food boluses normally cause the esophagus to contract in a smooth, coordinated downward manner, pushing that food down and into the stomach, like carefully lowering one of these sandbag weights. Nice and smooth. Nice and... Oh, God. Ugh. Oh, man. Got a rope burn. This is like the worst day ever. Well, as you can see, impaired inhibitory neurotransmission within the esophageal myenteric plexus can lead to diffuse, uncoordinated contractions, which is the case in diffuse esophageal spasm. Again, I want to contrast this with the diffusely relaxed esophagus seen in achalasia. That's right. It was only that lower sphincter that was contracted. Well, this time, the whole thing is just contracting all over the place. Just like achalasia, patients with diffuse esophageal spasm will also demonstrate a very classic finding on imaging. This time, characteristic corkscrew contractions will be seen throughout the esophagus on barium swallow. Esophageal manometry can also be used to diagnose DES and will show disorganized, non-peristaltic contractions. While the mechanism may be different, the end result is similar to what we saw with achalasia. Diffuse esophageal spasm causes food regurgitation and GERD. You got something coming out of your, never mind. Just like with achalasia, patients also experience dysphagia for solids and liquids. Hence the liquid overflowing from his lifeless mouth. Probably should check a pulse or... Nah, he's good. Look for a history of intermittent retrosternal chest pain. You're just walking around when, bam, sandbag to the chest. Don't even see it coming. Interestingly, the chest pain of diffuse esophageal spasm feels similar to angina, and the pain can even be relieved with calcium channel blockers and nitroglycerin. What? So the question stem will most likely involve additional symptoms such as reflux, and they'll probably give you that corkscrew esophagus on imaging. You never know though, so keep that angina anvil on your differential. Okay, it's time to wrap up this dysphagia musical with our last pathology, CREST syndrome. CREST syndrome is a specific variant of systemic sclerosis, which is an autoimmune disease primarily targeting the vascular endothelium, leading to chronic ischemic connective tissue damage, excessive activation of fibroblasts, and progressive tissue fibrosis. To represent CREST, we have, well, a crest. An old stage prop, it seems, from last year's universally panned production of Man of La Mancha. It's better to just keep those memories buried. The acronym CREST stands for calcinosis, Raynaud's syndrome, esophageal dysmotility, sclerodactyly, and telangiectasias. The sclerodactyly is represented by the scaly dragon talon, and all of the aspects of this syndrome will be covered in much more detail in our rheumatology unit. For now, remember that E for esophageal dysmotility. Esophageal dysmotility in CREST syndrome occurs because of atrophy and fibrosis replacement of the muscularis in the lower esophagus. Without smooth muscle to push ingested food down towards the stomach, this leads to decreased tone within the esophagus and dysmotility, leading to GERD that can progress to Barrett's esophagus. Just refluxing right up to that. Barrett's eyes. Penetrating my empty shell of Dude, jeezy crazy. No. Time to sum up the sketch. GERD is annoying, to say the least, but if left untreated, can lead to much more serious consequences. Chronic or untreated GERD can lead to Barrett's esophagus and eventually adenocarcinoma. All that glandy stuff and fluff. Smoking doesn't help either. It makes sense that most cases are seen in the lower third of the esophagus at the GE junction, where all that bubbly is happening. The classic patient with esophageal adenocarcinoma will present with dysphagia, weight loss, and sometimes chest pain and will most likely have a significant history of GERD. Squamous cell carcinoma, on the other hand, tends to affect the mid-esophagus and is most highly associated with irritants such as smoking and alcohol. Those are the big two to remember for the test. Patients with SCC will also present with dysphagia and weight loss, but may have a history of Plummer-Vinson syndrome, achalasia, or other esophageal diseases causing chronic inflammation. Speaking of, Plummer-Vinson syndrome is thought to occur secondary to iron deficiency and presents with the classic triad of iron deficiency anemia, esophageal webs, and dysphagia. Achalasia is caused by destruction of the myenteric nervous plexus of the esophagus and leads to increased tone of the LES. This leads to obstruction, dysphagia, regurgitation of solid foods, and increased risk for SCC. In developing countries, it may also occur as a result of Chagas disease. A little overboard with that Chay's gas. Either way, the pathognomonic finding is a bird's beak appearance on esophagram. Diffuse esophageal spasm is caused by uncoordinated contraction of the esophagus, causes dysphagia and chest pain, and has a corkscrew appearance on esophagram. And finally, CREST syndrome also known as limited scleroderma, is an autoimmune fibrosis of the distal esophagus that can lead to chronic reflux and development of Barrett's esophagus and adenocarcinoma. All right, we're making good progress here. Let's keep working our way down. Stomach, here we come.